Hello, everyone. I'm David Tsui. I just want to thank Dystonia Network of Australia for inviting me to speak to you guys today. My job today is to introduce my role as the movement disorder nurse practitioner in Western Sydney, and I'll elaborate a little bit about where I come from and what my job is about as I go through my presentation. So these are some of the things I will go through with you all about who I am, where I come from, how I structured my service, and how the role functions on a day-to-day basis. So who am I? I am the nurse practitioner in movement disorders for Western Sydney Local Health District, and I sit under the umbrella of integrated and community health. So prior to that, I worked as the clinical nurse consultant in Parkinson's and movement disorders and had the privilege of being mentored by Lorraine McAnally. I also sit as the co-chair for the Australasian Neuroscience Nurses Association under the branch of the movement disorder chapter. I'm also a board member of that association, and I previously was one of the tutors for the Parkinson's 299 subject at Australian College of Nursing. So in terms of my role, the geography that I cover is the whole of Western Sydney Local Health District. So my northern border reaches as far as Wiseman's Ferry. My southern border is somewhere around Lidcombe and Auburn. My western border sits somewhere around Cherrybrook or half of Cherrybrook. I never know which half. And also my eastern border sits somewhere just before Carlingford, so somewhere around Tilapia. So anywhere in between these borders are the areas that I cover. So in terms of the conditions that I look after, obviously Parkinson's disease being the most common movement disorder, that is something that I look after the most. But in context of movement disorders, I do look after people with dystonia as well. And so basically, anyone with a movement disorder can be referred to my service. So how my job came about was when I was in 2021, there was Dominic Perrottet and Brad Hazard injected $8.6 million into the local health districts to enhance movement disorder care for people. So Western Sydney opted to start a new service as a nurse practitioner position in the community, and this is how my jobs got funded to kick-started it in a way. So when we structured the role, we had to think about what is it that we actually need in our district. So what we found was that a huge gap in service was that we were having patients, very disabled patients with a lot of mobility issues, being transported into our clinics. They would come in stretchers with two patients transport service officers. They would have nursing escort. They would have family escort, and just the volume of resources that's put into transporting one patient to clinic was really ineffective. So in addition to that, often the nurse escort that comes with the patient do not have extensive knowledge of the patient. So the history taking process within our clinic is affected by that. There's also cost to the family. There's pressure on clinic staff to speed up their consultation and rush it. There's also pressures on the patient discharge unit because patients following the consultations have to wait in those departments for them to be transported back. Often there might not necessarily be the appropriate consistency of food for them and needs to be specially ordered. And basically basic nursing care such as toileting and pressure area care are neglected during those time periods when they are attending our clinics. And in addition to that, there was a massive time delay in accessing special neurologist care because they can only come every 6 months to 12 months as a routine visit. So this is the Director of Nursing for integrated and community health back then, Juanita Taylor and I sat down and we started developing the service together. She sent me for some clinical placements and gave me some exposure to community health, as I didn't have any community-based experience back then. And we developed a model of care, and obviously my nurse practitioner scope of practice, which was well received from the medical and executives alike. So what was the concept behind the model of care? So the concept of model of care includes, we wanted the service to provide continuity of care. We want it to be patient-centric. We want it to be free flow, where you can travel between different locations or within the health system and still be able to access this care. We also discussed things such as mixed model care delivery. We wanted a well-coordinated multidisciplinary approach, but we really wanted it to be movement disorder focused. So our inclusion criteria for the service was that anyone with a movement disorder can be referred to our service, and all internal referrals from Western Sydney will be received. But however, in order to trim down the amount of volume of referrals that come through, we had to exclude anyone without a diagnosis of movement disorders. And we were limiting referrals directly from GPs and aged care facilities because we don't want to duplicate or over branch into the realm of where a neurologist should be managing the patient. In terms of care delivery, there are 5 main areas of care delivery. So the first one, which is the main concept of this service, was aged care facility visits. So I would drive out in a fleet car, go and see patients in the facility, provide recommendations and follow-ups. Home visits, I would attend people's private residence and review patients in their homes. Telehealth is a huge component of my role, where I would contact patients to provide support, particularly in the medication titration processes, following up their response to medications and so forth. And then in the context of dystonia, it might mean that it might be a phone call following their botulinum toxin injections to make sure that they are responding appropriately and there's no side effects such as weaknesses or swallowing difficulties after the injections. I also provide an open access clinic, which is sort of what we call a drop-in clinic, where if you need a really urgent review, but not urgent enough where you need to present to emergency, then that would be something that we would see, a location that we would see you in. And in addition to that, I would sometimes go to the hospitals to see patients in emergency departments or inside the wards. Now, in terms of my workflow, this is what I basically do on a day-to-day basis. I would triage referrals, and then I would provide some initial telehealth planning consultation, where I would triage how severe the problem is and how urgently I need to go out and see the patient. I then provide a face-to-face consultation, and then we determine whether the care that I'm providing is just episodic, meaning I have a short-term relationship with the person, link them up with the appropriate services and discharge them, or whether they become my long-term patients and these are generally reserved for people who are in aged care facilities and don't have access to specialist or neurologist consultations. And then obviously, if they are safe for discharge and stable enough for discharge, then they would be discharged following that. In terms of the benefits of the service, we found that it was very comfortable for patients receiving the care because it reduces the unnecessary travel. We would also help Allied Health to provide more targeted approaches. So when I assess the patient, I might say to the physio, this patient has this particular problem. Could you focus your physio and sessions around this symptom? So this would provide Allied Health a bit more targeted approach in their therapy sessions. In terms of discharges, expediting discharges, so an emergency department might allow patients to be discharged earlier because I'm going to see them shortly after their discharge. And this would avoid any unnecessary hospital presentations or readmissions. In addition to that, it is faster to see me than it is to see a neurologist, so access to expert advice becomes a little bit easier. And the last thing is adherence to care. So a lot of patients, they would have a medication titration plan that the doctors give them, and then later on they might forget or they might not adhere to it because of some expected side effects. So our job in those instances is to provide reinforcement, re-education, and encourage the patient to persist with the duration of the titration processes with the medication adjustments. In addition to these things I usually go around doing is attending support groups. So this is a Blacktown Parkinson New South Wales support group where I provide a little bit of education, raising awareness, and also promoting the service. And this comes to the end of my presentation. So if you have any questions around this presentation, feel free to reach out to me on this email address. So I just want to take this opportunity to thank Lorraine McAnally for inviting me again, and I hope Dystonia Network of Australia has all the success in the world. Thank you so much.